I'm Michelle Crawford with Crawford Benefits.
And I'm Jamie Meredith with Crawford Benefits as well. And thank you guys again for joining us. This will be our first one, so we're excited to see how it goes. And thank you for hopping on and joining us.
Yeah. At the end, we'll leave some time for questions. So if you do have questions along the way that have not been answered, go ahead and drop those in the chat, and we'll address those at the end.
All right, so we wanted to talk about the Inflation Reduction Act. It's a new, or it's not new, but there's new changes that have been implemented for 2025. And we're going to talk about the changes that kind of circle around what we do, more so on the prescription drug aspect of it. So we'll talk a little bit about what the Inflation Reduction Act is, what the changes are that apply specifically to Part D, how they'll kind of impact you, and then some questions that we've gotten, regularly throughout the year.
Sounds good. Yeah, the Inflation Reduction Act, as Jamie mentioned, it centers around the prescription drug costs, really, as far as what we're going to talk about. But it has 4 stages. So in 2025, this is stage 3 of 4, which is probably the biggest one, where we've got, new caps on drugs and, prescription payment plans and things like that. And then going into 2026, Medicare is going to be negotiating costs on some of these expensive medications with the pharmaceutical companies and manufacturers. So we're going to talk a little bit about that today, and also talk about what we saw during the enrollment season and questions we've had since then.
Yeah. Let me see. Okay. So you talked about the $2,000 cap on drug costs. That's probably the biggest change that we saw this year. And it applies to the most people, I guess, than any of the other changes. It's where, you've got the deductible phase for your drug plan, and then the initial coverage phase. And then once you've paid $2,000 overall in prescription drug costs that are covered by your plan, that's the cap. So you don't pay anything over $2,000 for covered drugs. That's big because it's lowered the cost down from over $8,000 last year down to $2,000. So it has the potential to save people a lot of money, specifically that have those higher cost drugs. It also expanded the subsidies for low income beneficiaries. So specifically for the Extra Help program, which is help paying for prescription drugs, they've expanded that to 150% of the federal poverty level, up from 100% from 2024. So a lot more people are going to qualify, which means a lot more people are going to get help paying for those extra drugs.
And a lot of people probably don't know that.
Yeah.
So people who may have applied for extra help in the past and been denied, I think that our advice is, let's take a look at it again. When you're looking at those numbers, though, the income, and I think you've got the actual numbers, but it's important to add back in your Part B premiums, because if all you're looking at for your income number is what's being deposited into your bank account every month, when you go in and you add another $185 a month, especially if you've got a household, that's $370 a month.
Yeah. That
could put you outside the guidelines. So you want to talk about those numbers?
Yeah. So on a monthly basis for a household of 1, if your income before any deductions is under $1,882 a month, then your income level will be under 150% of the federal poverty level. So you might qualify for extra help. And for, a married household, you're looking at $2,555 a month. There's also not just income, but resource allowances too. So if you have over a certain amount in resources, like stocks or retirement accounts, extra properties, things like that, those are going to be factored in. But income wise, it's, the limit's been increased.
So they'll allow you to have your home that you live in and a vehicle.
Right.
But if you have over that, or you have money in the bank, they're going to look at all that stuff. So
right.
That could put some people out of those guidelines as well. So going back to the cap on the 2,000, I think it's important to note that we went from never having a cap on drugs at all in 2023 to in 2024 it was capped at 8,000. to in 2025. Now it's 2,000, and that, the question I got a lot this year was about the donut hole. People were in the donut hole or the coverage gap, and the drugs were very expensive. So what this $2,000 cap does is it removes that completely, so it doesn't exist anymore, which is going to help a lot of people.
Yeah, it's so sad to see whenever you meet with someone and they've got, it didn't happen as much this year, but in past years you'd see someone that has a copay of $350 for the husband and same for the wife. They've got that every month for 6 months straight. It's devastating to see that, because their question is, how do I pay this? Not, it's
They're living on a fixed income.
Right. So this has the potential, like we said, to to save people a lot of money that are paying that out.
Negotiating high cost medications. We talked a little bit about that. That's part of the Inflation Reduction Act, and we're really going to see that more in 2026. And they're going to do it in stages. So there's a list of 10 medications that are on the radar for 2026. And some of those that we see a lot of are Entresto, Xarelto, Farxiga. I think Jardiance is one of them. So we've got 10 for 2026, and then going into 2027, they're going to add 15 more drugs. In 2028, they're going to do 15 more. And in 2029, which seems so far away, but it'll be here before we know it, I think they're going to try to add 20 drugs each year to that. But when they do that, I think we also need to be aware that these carriers, because of this cap of the $2,000, which, who pays for everything over the $2,000? That's something that people really aren't talking about. But the carrier's on the hook for paying 80% of everything over the $2,000, and Medicare pays the other 20%. So the carriers are going to be looking for ways to reduce their exposure.
Right.
When they go to these pharmaceutical companies, when Medicare goes to them and starts negotiating these costs, it stands to reason that they may not be putting as many drugs on the formularies. Because if they get a better rate on, we'll just say Eliquis over Xarelto, and I'm just using an example, they don't have to offer both of them. The Medicare guidelines state that the formulary, the list of medications covered under the plan, have to include one brand and one generic in each drug classification. So they don't have to offer all these drugs, and I think it's highly probable that they won't. We talked a little bit yesterday about, I had a client who had 4 medications, so not a long list of drugs, but when I ran the analysis for his medications for 2025, there was only one plan that covered all 4 of his medications.
Yeah. And that's no fun. Normally you can look at it and say, you have 5 plans that are going to cover all your drugs. This is going to be the lowest cost for you. This one would be lower copays, but higher premium and so on. But when you just, hey, you can do this one or not have your drugs covered. And I saw a lot of that too. And it's something that, we've never seen before. There's always, or usually always, multiple options for people unless they have some, brand new off-the-wall medication.
Yeah, I just think that we're going to see more and more
tightening down.
Yes, definitely tighter formularies. And the carriers, unfortunately, can change their formularies throughout the year, which is unfortunate. It's one thing that I would like to address with the government, is that seems unfair.
Yeah. If they're held, if the members are held to, I can only change during open enrollment or special enrollment periods, but the plan can reevaluate 3 months down the line and say, oh, this isn't the best deal for us. We're getting having a lot of costs.
Unfair.
Yeah. With Medicare being one of the most regulated industries ever, and they can do this, seems, it should be illegal. I don't know why it's not, but I've talked to a lot of people and said, we need to write a letter and stuff like that. But it's true. It's not fair that they can do really whatever they want, and you're held to the guidelines that you are.
Yeah, for sure.
Yeah. The Medicare prescription payment plan is another thing that's being implemented for 2025. A lot of people, I'm sure, already signed up for it, but what it is a way to not reduce your costs, but it's a way to budget more and spread out your costs over the year. So rather than paying a copay for your medication at the pharmacy, you could, if you're signed up for the prescription payment plan, you can choose to not pay the copay at the pharmacy and have it be billed to you by the carrier. So instead of paying, $100 for your prescription, now you're making 12 payments for that prescription.
Right.
It has the potential to help people with their monthly costs and figuring that out. It could create a little bit of uncertainty with budgeting because the bills might not be even. If you have $200 that gets added on in January, they divide that out by 12. And then if you have another $200, now you've got 400 minus whatever you paid in January divided out by 11, and so on. So your payments could be a little unpredictable. What we had talked about before is, the carriers, when you get set up on this, they will want you to do an automatic payment method so that they can guarantee you that they're going to get a payment each month.
Right.
But what you have the option to do is set up for a direct bill, so they send you a bill. So even if if the minimum payment is $50, but you're going to continue to have high drug costs throughout the year, you could pay $200 if that's comfortable for you, and it'll help reduce having this large balance at the end of the year.
Yeah, you have to at least pay what they bill you, but when you're getting the direct bill every month, you have more control over what you're paying. And I called in with a member, and the carrier, because in order to sign up for the plan, you have to call the plan. There's not a form that we can help our clients fill out or anything like that. So you have to call the plan, get signed up for that. It takes about 2 weeks for it to even hit the system. So if you need to sign up, or you think you might need to sign up, you need to do it sooner rather than later. But when I was on the phone with a client and with member services, they were really pushing for a payment method, and they really made it sound like you didn't have a choice. So had I not been on that call with the member, they would have given them a credit card. But that wasn't in their best interest. And it's not in your best interest because unless you're filling $2,000 worth of drugs in January, your numbers are going to be unstable throughout the year. And depending on how you're filling your medications, you could be flipping your high cost from January to December. So you're better off to do the direct bill and just make sure you're paying, like you said, if you know that your drugs are going to cost $2,000 for the year, and you get that bill for $40 because that's what you had to pay for January, you can still pay $160, and then you're going to have smoother costs throughout the year.
Yeah, 100%. And you talked about how to enroll. So I mean, it's a really, really good program. But if you, like you said, if you wait until you go into the pharmacy and they say that'll be $600, that one is going to be too late to do
right.
That.
So if you would benefit from it, if that deductible is going to be a burden if you had to fill it, even if you don't have high cost medications now. If the simple fact of having to pay $590 to get a drug filled, or potentially even more, if that's going to be a burden, then go ahead and get signed up for the plan. And that way, if you do get a prescription that applies to the deductible, you're prepared for it, and you don't have to sacrifice your care by not getting that drug filled on time.
Yeah, and to that point too, the deductible for you might not be a problem, but if you and your spouse, if you're married, both have that same cost in January,
in the same month,
I mean that could definitely be uncomfortable. So you want to, if there's a possibility that it might be a benefit for you, go ahead and sign up.
And we got a lot of clients who would forward us the documents that they got. The carriers sent out letters about the Medicare prescription payment plan, and I think it was confusing to a lot of people because they thought they had to do it. And you don't. It's a voluntary program, but if paying those expenses all at one time is going to be a burden for you financially, or a shock even, then I think you can benefit from the plan.
Yeah, and just to reiterate, because there are programs out there that are designed to cut costs for Part D. This is not one of them. It does not save you any money. If you have $2,000 in drug costs, you will still pay $2,000.
Right.
It's just a way to kind of spread it out, make it more even and more manageable. I just like to point that out. So who benefits the most? We talked about who would benefit the most from the prescription payment plan, but on the Inflation Reduction Act as a whole, who do you think is going to?
It's really people with high cost medications, because this is designed to put a cap, a very low cap in my opinion. I mean, it's not that $2,000 isn't a lot of money, but when you factor in the fact that in 2023 we didn't have a cap at all, and then it dropped to 8,000, and now it's 2,000. That's a really drastic change, which is, from a business perspective, is not a good thing. It's too much, too fast, in my opinion. But the people with high cost medications are really going to be the ones that I think are going to benefit the most. People who don't have medications or don't have high cost medications, over the next few years, I think they're going to benefit. It's going to negatively impact them, because we're going to continue to see prescription drug plan premiums go up, deductibles go up, deductibles apply to more things, and I think that that's not going to be helpful for them. But also people who have low income. I mean, because of the expansion on the extra help, that's going to be helpful for a lot more people. And we just want to encourage people to give us a call, and we can run through an application for them. They don't have to do it on their own. We can do that for them. And then, people with multiple high cost medications.
Yeah, that's back to the, just applying and seeing if you qualify. There's a lot of people that, they say, oh, no, I wouldn't qualify. But with those new guidelines, you never know. And if you apply and get denied, you're in the same spot.
Right.
You didn't lose anything. So it's important to at least look at that. So different ways that people can prepare, and this isn't, specific to the Inflation Reduction Act, just how can they prepare each year? I know the biggest one that I always tell people, and I hear you say, is, doing an annual review. I know that's what we do. That's the biggest part of what we do, but it's big to look at your drugs, because these plans change every single year. Even if you haven't had a change in your drugs and you've taken the same 2 medications for the last 10 years, they might not be covered next year, or they might be covered, but they're at a different tier, or now your drug plan is exiting the market, or whatever the case may be. So it's always important to at least look at it. And, best case scenario, we look at it and say, you're on the best plan,
Right.
Great job. You don't need to do anything. But, you only have that October 15th through December 7th window outside of some kind of special enrollment period. So it's important to look at it then and make sure, just to know that you're on the right plan.
Yeah, we talked about this before with, several years ago, there was a low cost plan. It was like $7.30. And for people who didn't have medications at all, that was the plan we put them on, because that was the lowest cost to meet the guidelines.
Yeah.
And then that transitioned to $15.70. Well, that plan went away this year, and anyone on that plan, now they're on a plan that costs $50.70. If you don't have any medications, and you're now paying $50.70 as a placeholder.
Yeah.
And that's definitely not the best place for you. But outside of a special enrollment period at this point, you're stuck for 2025. But it's a good example of why it's important to look at that stuff.
Yeah.
And, we've got a carrier out there that, in 2024 had, a 50-cent drug plan, and in 2025 they've got a 0 premium plan. And personally, I think that's a strategy to gain market share. I think that is a plan, and everyone on that plan is something to look at going into 2026, because I think that plan has the highest potential of changing and negatively impacting people who stay on that without actually evaluating it.
Yeah, I couldn't agree more. I was expecting that to happen this year, because it was 50 cents, and everybody said 50 cents. How can it be 50 cents? And then it went to 0. I said, okay, something weird, something weird is going on.
Well, I mean, just the simple math. If they go from 0 to, let's say, $20 in premium, and I'm just making numbers up, but if they've got 1 million people on the plan, which we know they have a lot more than that, I mean, that's $20 million in revenue.
Yeah.
If they tweak the formulary to pull some things off or drop the deductible, they just generated an enormous amount of revenue.
Yeah.
So I do think it's a strategy and something to be watching.
Yeah. I the third point on there says to stay informed. And I had someone come in the other day and they were talking about the late enrollment penalty that they got because they didn't sign up for Medicare right when they were first eligible. And they said, somebody had to have told me about that. And I pulled out my copy of the 2025 Medicare and Me. I said, have you ever seen that? They said, oh yeah, I get it. And I just throw that away. I said, well, it's in there, And I know that no one reads this, but there's people on all ends of the spectrum. We have people that come to us that they've heard of Medicare before. We have people that come in and they've got that book and they've
read it cover to cover.
Oh yeah, it's got highlights on every page and pages dog-eared and all that. So staying informed though is big. I tell people don't take my word for it. I want you to I want you to research it. This is I'm trying to make you aware of all the information that's available, but I always encourage to just stay informed.
Yeah, absolutely. And I think that with Medicare being such a highly regulated entity, the information is out there and Medicare gives you the information, but what they don't do a good job of, in my opinion, is making it understandable, relatable to you. And when I think the benefit that our clients find with us is that we boil it down to what's relevant to you as a client. So there's a lot of information that Medicare and you, however, a lot of it doesn't pertain to every single person. And so when you're meeting with us and we get to know you and understand what your situation is, we can help pull out those nuggets of information that are going to be applicable to your situation and help you guide you through the situation.
Because they send, you'll have a stack of mail this big for Medicare and this much applies to you, but they're required to send it all out. It causes more confusion sometimes than others. So this would be our, I guess, forecast of what we've seen a little bit of and what we think that this is going to kind of transition into. So it's not necessarily anything that's been put out by Medicare or by any carrier saying this will happen, but just what we've seen so far and what we anticipate.
Yeah, and probably the biggest thing I think that we've seen is fewer options. Yeah. So we went from having 20 drug plans, Part D plans in 2024 in the state of Georgia, which is really nationwide because most of the plans are nationwide, to having 14. And so that's a 30% reduction. And of those 14, 6 of them were priced at $100 premium and higher. One of them was almost $160, which is more than a lot of people are paying for their supplements. Yeah. That's huge.
Yeah. It's something that we haven't seen before. And that just, it blows my mind. You have a zero premium plan, but with 6 over $100, and if you've
it's almost 50% that are over $100.
Yeah,
and
if you were one of those people, just riding it out, not making changes, and now your plan's $120 or $150, that's going to be that's
a hard pill to swallow.
Yeah, yeah, exactly. The another thing was prior authorizations. We've seen more. You always expect to see it on the high cost drugs like the ones on the list you mentioned, Eliquis, Xarelto, things like that. But there were a lot of prior authorizations this year on sub $10 medications.
$3 medications.
Yeah, and you look at that at first and you think, that's got to be a mistake or something. But I know you mentioned it is likely a strategy of, if they can make one more hoop for you to jump through, a lot of people are just going to say, I'll just fill that drug through GoodRx or through, I'll just pay for it. And what that does is free up so much extra revenue for them because, 1 million people every month not filling a $3 medication is going to do numbers for their, for their bottom line. And that could create more problems for you because now the costs that you're filling outside of the plan aren't going towards your $2,000 cap.
So you're paying more money than you need to.
Yeah, you're paying more money than you need to. And, you're likely paying a little bit more for that drug off the plan anyway. So it's very, kind of sneaky of a thing to slide in there.
But it was interesting because we saw it a good bit. $15 medications, $3 medications. I think that $3 one was probably the most startling. I did a double take because it didn't make sense. But again, strategies. These carriers they're scared. They've had to make really tough calls. I'm going to be interested to see what happens on the formularies throughout the course of the year with drugs changing that, they were covered, when we did the analysis and maybe they pull them back. So that is something to keep an eye on. But they're having to make hard calls to minimize their exposure because they have to pay 80% of everything over that $2,000. They don't have any control other than putting in prior authorizations and managing their formularies.
Yeah, I mean, when you think about it, and take a step back and look at the carrier costs or potential costs. If you're on a $10,000 a month cancer medication, your total responsibility for the year is $2,000. The cost for that drug is going to be $120,000, and they've got to pay 80% of that after $2,000.
Right.
I mean, having that exposure from 2 years ago, having almost no exposure or no skin in the game for them, it caused a lot of panic. I would say it was, a lot of the carriers, you mentioned before, started pulling back those extra benefits. You saw a lot of dental and vision and over-the-counter benefits on Medicare Advantage plans just stripped away entirely or just the bare minimum. You saw a lot of co-pays on, specialist visits going from $15 to $35 up to, $40 to $55 on a lot of plans.
Right.
So it's, you saw that along with a lot of other changes and updates coming out almost daily as soon as the enrollment season started, because, they know they're going to take a hit from this, and they're just trying to, find every way possible to reduce the non-essentials.
The carriers not paying commissions to agents. That was a big one this year. That was obviously a hard pill for us to swallow, but we had to adapt our business plan and our business model to accommodate that. But again, the carriers were just really looking for ways to minimize their exposure because they are scared. These were some drastic changes this year. So we'll be keeping an eye on everything and see how it develops throughout the year.
Yeah. I'm always weary when someone is trying to help out of what the intentions are. And I think the intentions of the Inflation Reduction Act are good. Who doesn't want to reduce the cost for everyone? But that comes at a cost. You're shifting the cost to
the residual impact.
Yeah. You can't just make the cost zero or, cut the cost at $2,000 and everything else stays exactly the same.
Right.
That cost gets shifted to a company, and the company is going to shift the cost to the member eventually. Yeah. So, hopefully I'm wrong and this just goes, just as smoothly as can be, but that's kind of what we're expecting to see.
And then we had higher deductibles this year.
Yeah.
They went from the standard deductible went from $545 to $590. We saw plans that may not have had deductibles in the past implement those. I think that those deductibles are going to continue to climb. Again, Medicare allows a $45 change per year in benefits, and they took full advantage of that $45 this year. I expect that's going to continue, which is why the Medicare Prescription Payment Plan, also known as the M3P, is going to be important for people to have access to, because as those deductibles increase, it's going to be more and more problematic for people to fill those drugs in January.
Yeah. A scary thing for me that I saw a lot of was the max out of pocket that Medicare allows for Medicare Advantage plans went up to $93.50 this year for in network. I think it was $14,000 or so for out of network.
And that's only medical.
Yeah.
So that's in addition, you've got your $2,000 drug cost.
Yeah, and that almost $10,000 as a max out of pocket is crazy. And like you said, this isn't going to go backwards. It's going to continue. So, in a couple of years, we'll have max out of pockets of over $10,000, I think. Yeah. Let me see. Did we have any questions or anything come in? Okay. So when, I kind of compiled a little list of, what questions we were getting a lot throughout the year in different meetings. One of them was, what is the formulary and how does it affect coverage? The formulary is going to be the all-inclusive list of every drug that's covered by the plan. Most of them are, tiered. There will be different tiers assigned to different drugs. For the most part, the higher the tier, the more expensive the medication is going to be.
But not always.
Yeah, not always. There's certain ones that are up there. Usually, if you see a tier 5 versus a tier 1, it's going to be a higher cost.
Right. Yeah. The thing on the formulary too is to understand what Medicare guidelines are. And Medicare requires the carriers to have one brand and one generic in each drug classification on the formulary. which I think we hit on that a little bit earlier as far as, when the carriers are negotiating these drugs or that Medicare is negotiating the drugs, they only have to have one brand and one generic. Yeah. So, for example, Eliquis and Xarelto are blood thinners, their brand. Coumadin and warfarin would be generic. A carrier only has to offer one of those. So, the formularies are going to change. They're going to start, in my opinion, being reduced because they don't have to offer them all, and they're going to look for ways to minimize their exposure.
Yeah, that's it's just part of the residual effects that are going to come from that, more than likely. So we touched on it just very briefly about the prescription payment plan when we talked about it, as that is not a form of financial assistance, just a way to break it up. But a lot of people ask, what are some forms of financial assistance that are available for your drug costs specifically? And there's a few different ones. The main ones being extra help and Medicaid. Right. Extra help is from Social Security, and it's help for paying for some of your Part D premium and your Part D drug costs. And like we said, it's expanded to 150% of the federal poverty level is the income guidelines. So people that didn't qualify before may qualify freshly this year. So it's a good thing to check and see if if drug costs are something that you struggle with.
And then the Medicaid is at the state level.
Right.
So that's also income based. So you've got, the extra helps at the federal level and Medicaid at the state level. So those are two resources that are potential savings options.
Right. I think you might have touched on it before, but a lot of people asked, what is the donut hole or the coverage gap?
That doesn't exist anymore, but in 2024, it was the third stage of coverage where, when you reached that coverage or that stage, you were paying 25% of the retail cost of your medication. So it was expensive. Mm-hmm. And you continued paying that until your true out-of-pocket expense was $8,000. So that's gone. Mm-hmm. That doesn't exist this year, so we don't have to worry about that anymore.
Good. That was, that was something that was just seemed to be detrimental to people. You get in that, and you're just going to be stuck for a while. Yeah. Another question I get a lot, or it's something that people don't even think about a lot, I think, is do all pharmacies, specifically some of the smaller pharmacies, take all the Medicare Part D plans? And that's something to check with your doctors to see who they're in network with, but you don't always think about the pharmacy. And that's big, especially with the smaller pharmacies. You want to make sure that they're in network so that you don't go to fill your drug and you're paying $600 a month out of pocket, and none of it goes towards any of your Part D costs. So you want to check and make sure. And one thing that I've run into specifically last year that just stuck on my brain is if you or someone that you love is in a long-term care facility. Mm-hmm. A lot of times they use specific pharmacies for the long-term care facility. You can't fill it outside of that. So that is important to make sure you are checking the prices through there and not just a local pharmacy, because you won't be able to fill it otherwise. Right. So that's a big one to check.
And then the Part B benefits. Not all pharmacies are filed with Medicare to be able to bill for Part B. Mm-hmm. So, a challenge that people will call in about is, they go to fill maybe their test strips for diabetes or their needles or things like that. And they're having to pay for it, which mm-hmm. if they have a Medicare supplement and it's covered under Part B, you shouldn't have to pay for it after your deductible's been met. But the problem ends up being that they're filling it at a pharmacy that's not qualified to bill Part B benefits. So they are incurring costs that they shouldn't have to. So, make sure that if that applies to you, that you are using a pharmacy that is filed with Medicare to bill Part B benefits.
Yeah. And that's one, like I said, you're not going to know until you go to do it. And they might not even tell you we're not filed to bill Part B. They'll just tell you what the cost is, and you have no, you just won't know otherwise. All right. These are the, sources, just to cite everything if you need to take a screenshot of that. Yeah. And man, some good looking people.
So I think that's it. I don't think we had any other questions, and we hope that everybody found this informative today. We look forward to doing more of these in the future, just kind of keeping people informed on what's going on. And if you find that you had some questions, maybe that's plan specific to your situation, you can always give us a call or email us. If you need help signing up for extra help, give us a call. And thank you for your time today. Everybody have a great day.
Yes. To